Hello again, Becca Mullen here, Assistant Professor in the Department of Family Medicine. I am back to give you another lecture, lucky you, second week in a row. This is week 2 in your mentation unit of the Geri Care Everywhere training program, and today we will be talking about caregiving in dementia. So let's just jump right on in. Here are our learning outcomes for your Caregiving in Dementia lecture today. There are 3 learning outcomes, the first being caregiving in dementia with our objectives to describe characteristics of dementia caregivers, understand the typical roles and needs of caregivers for persons with dementia. Our second learning outcome focusing on the well-being of caregivers and bereavement, with our objectives being to identify issues related to the emotional and social well-being of dementia caregivers, and to describe grief and bereavement in dementia caregivers. And our third learning outcome being about supporting caregivers, with the objective to identify resources and services to support caregivers. And this learning outcome will really be sprinkled throughout the entire lecture, but it is important enough that we've separated it out in a separate learning outcome here. Okay, before we move on, a very important note I might add about definitions and terms. So there's really no one gold standard definition of caregiving. But I think a very fair or very good definition to lean back on would be that caregiving is attending to another person's health needs and well-being. So you can see that that really can be interpreted in a variety of different ways depending on the individual's needs and what they are kind of requiring at that time. I also want to make note of the potential shift in the way we're thinking about using the word caregiver in the dementia space versus using the word care partner or even support person or even to be determined, another term that I don't have listed here that may also be new and upcoming. And I will use the word caregiver in this lecture because it was the title of the lecture, and I think it is still, obviously the most common term used today. But I do want to put a plug for moving towards the other terms listed here, such as care partner or support person, as I really do think that they're more inclusive to what is really happening, particularly at the earlier stages of cognitive impairment, such as when a person has mild cognitive impairment or even mild dementia, and they really are largely still independent. I think in that circumstance, there is a high likelihood that the person with the disease will not identify with having a caregiver. And it's also possible in that circumstance that the person who may be helping them or aiding them or tending to their health needs and well-beings will also not identify as a caregiver. So I think we may lose the ability to help someone in that circumstance in regards to identifying them as an individual who's aiding the person with diagnosis and be able to give them resources by trying to use a label of caregiver and not having them really identify with that term, versus if we were to use a more inclusive term such as care partner or support person, they may be more likely to identify with that, and we may be more likely therefore to be able to simply acknowledge them and give them resources. So again, I will use the term caregiver in this throughout this entire presentation, but I do want to put a plug for actually moving towards more the term care partner, support person, etc. So let's just start a little bit just by talking about kind of demographics and characteristics of dementia caregivers as a whole. We know that by far most caregivers of persons with dementia are unpaid family members or friends. So 83% of dementia caregivers are what we would consider to be informal caregivers, meaning they're unpaid and they are family members or friends. And over half of these dementia caregivers are taking care of either their own parent or an in-law. And when we look at the demographics of dementia caregivers, we see that most are women. So about 2 in 3 are women, and 1 in 3, or 30%, are 65 or older, so are older adults themselves. We are seeing an increasing amount, though, of dementia caregivers in a young adult or more middle-aged age group. So 23% are in the 18 to 49 year age range, and this is increasing about 7% from the years 2015 to 2021. And 1 in 4 are in a sandwich generation caregiver designation, meaning they care for both an aging parent and at least one child under the age of 18. We also see that 57% of dementia caregivers, so most, provide care for 4 or more years. This is not a short-term commitment. And 41% of caregivers have a household income of $50,000 or less. There is talk of this potential future family care gap. So in thinking that by far most of our dementia caregivers are these unpaid family caregivers, there's a concern that we're going to have a point in time where we're going to actually lack having access to caregivers because of this, that we're relying too much on unpaid family help. And this is for a few reasons. First, we know that Alzheimer's disease and related dementias are on the rise, both because of we see the prevalence of dementia increasing, and that we also don't have a cure for these diseases. And we also know that there is an aging U.S. population in combination with these issues of dementia being on the rise. And then on the opposite side of that, we see this concern about the availability of these family caregivers potentially waning because of things like lower birth rate and also adult children with their geographic mobility and dispersion just not physically being near their parents that they would potentially being taken care of. So put all of these pieces together and it brings this concern of a potential future family care gap where we have this crisis of not having enough family caregivers and really needing more assistance with policy and infrastructure to healthcare infrastructure to help take care of older adults with dementia. So what do caregivers do? Well, obviously they may have many roles, but generally speaking, caregivers help with providing support and companionship, maximizing independence and function, and planning with the future. And the role of a dementia caregiver specifically, as you would imagine, heavily depends on the functional status of the person with cognitive impairment. So you remember last week we talked in detail about the stages of dementia and how the symptoms of dementia really change as you go through those stages. So the role of a dementia caregiver heavily changes as you move through those stages. It's also worth noting that the type of dementia also impacts the role of a dementia caregiver. Now, I'm not going to really go into this into detail because we, in the purpose of this lecture series, haven't talked in detail about all of the different types of dementia, really just focusing on Alzheimer's, which is, as we talked about last week, by far the most common type of dementia. But just as a brief example of what I'm talking about here, there is another another type of dementia, frontotemporal dementia, where the primary concern, even presenting concern in some of the earliest stages, is really more about kind of behavioral and personality issues. And so you could imagine if that's some of the earliest symptoms and presenting issues that a person or an individual is going through, that the caregiving experience would be very different in that circumstance than someone with Alzheimer's, where the earliest symptoms are really more about memory. And so that's all just to say that the stage and the type of dementia really impacts the caregiving experience. But generally speaking, we see here that we can illustrate the dementia caregiver overarching goals and priorities based on the dementia severity. So based on mild, moderate, and severe dementia severity. And so in mild dementia, primarily, a dementia caregiver's goals and priorities will be to maximize independence and plan for the future. So remember here, in mild dementia, individuals are still largely independent, and symptoms may mostly just be noticeable to close family or friends. So some individuals may require some assistance with some instrumental activities of daily living, but some may not. And so you can imagine putting yourself in a caregiver's shoes that really the goal here is going to be to continue to boost and maximize that independence, and then also to take advantage of the mild symptoms and to plan for the future as much as possible. In moderate dementia, which again, as a reminder of last week, is often the longest stage of dementia, individuals may experience more problems with memory and language and start to require more assistance with daily tasks. And they may have increasing inability to recall personal information, have more personality changes or behavioral changes. And this is where you often might see that they start to wander or get lost. So there may be increasing concerns about safety or driving. So putting yourself in the dementia caregiver's shoes, often the utmost goals and priorities become, first and foremost, safety, to assess safety and to maximize safety. Also to support function and those IADLs and ADLs. As you start to see that someone may be, that those may start to wane, you as a caregiver may want to start to support a person as they're no longer able to do those IADLs and ADLs themselves. And then finally, to manage symptoms, both behavioral symptoms, psychological symptoms, but also physical symptoms. And then finally, in the severe stages of dementia or in the late stages, this is when individuals often lose the ability just to respond to their environment completely. They may not be able to carry a conversation or even control their movement any longer. And this is where you may see significant personality changes. Individuals may even experience hallucinations, incontinence, dysphagia or difficulty swallowing and aspiration, impaired gait, and this is where individuals often require around-the-clock care. So when we think about the goals and priorities of dementia caregivers in severe dementia, it's usually focused around preserving quality of life and dignity for that individual. So how might a caregiver successfully meet those goals or priorities with each stage of dementia? Well, you would imagine with each increasing stage of dementia, the caregiver is going to have differing needs from the healthcare system, from a community referral, even from their own support group and from their own individual network system. And so as a reminder, the priorities of a caregiver in mild dementia are typically to help maximize independence and plan for the future. So in mild dementia, the information that a caregiver most needs and benefits from are likely around information about the disease progression, how to navigate the healthcare system, including things like how are they going to get a referral to, for example, a neurologist? Do they need a neurologist and if so, when, what type of imaging do they need, what further tests do they need, how often do they need follow-ups, etc., and information on treatments and clinical trials. This is where it's also very important and just of utmost very vital, I should say, to start conversations about advanced care planning and financial planning. So when the disease severity is the most mild, so the person with the disease can really contribute the best to these conversations. So thinking about things like wills and trusts, life insurance if they want long-term care insurance, medical durable power of attorney, who's going to be the decision makers, etc. So it's very, very important to be having these conversations as soon as possible. Additionally, it's really important to recognize the emotional toll that caregiving takes even early on. This is a significant transition for any person to go through and a major shift in any relationship. So supporting caregivers as they adapt to this new role and potentially helping them think through and deal with maybe even the denial of a diagnosis and managing their stress can be very important. Another way to think about caregiver needs in mild dementia is to frame the needs around caregiver education after the diagnosis, and then think about the key resources available to caregivers in the healthcare setting. So caregivers can be referred to social workers or care managers who could then help bridge them to, for example, community resources or other entities that may be helpful to them. They could also be referred to behavioral health, who could help them think about how to manage the stress and help their overall well-being. There are also disease-specific organizations that can provide an immense amount of information around, for example, the diagnosis, prognosis, and treatment. For example, the Alzheimer's Association in particular provides an immense amount of resources for individuals, both those with the disease and caregivers alike. For example, they have a 24/7 helpline that offers free, confidential support and information to people with dementia or caregivers or family members. You can call there with questions about, for example, care planning or what to do after a diagnosis anytime, obviously, because it's 24/7. The Alzheimer's Association also hosts their own support groups, which you can find information about online, including support groups specifically for caregivers, and even specifically support groups for caregivers for those who are in the early stage. So again, just a very, very helpful place to go when you are kind of talking with caregivers after a diagnosis and they're seeking information and trying to educate themselves. And there are similar websites for other dementia, such as frontotemporal dementia, Lewy body dementia, etc. And I just want to also point out that this is also one of the benefits of an early diagnosis, that care partners, for example, can be referred to all of these different resources during a time frame where when I should say, the burden of caregiving may be lower and their ability to focus on learning and preparing may be higher. And so this is, again, when we're thinking about why do we want to do early detection and early diagnosis that we talked about last week, this is another one of those reasons why. So during the middle stages of dementia or during moderate dementia, caregiving responsibilities become more demanding. And here it often becomes even too difficult or even dangerous for a person to be left alone. And here it can become crucial to prevent wandering and consider safety precautions in the living environment. And if a person with dementia is living alone, this is where they may need to move in with relatives or consider a residential care setting. And I do have more details on the next slide about doing a safety assessment. And so that is one key piece here where a caregiver may need more information about safety assessment given the ongoing and increasing needs of those with moderate dementia. They also may need more information about how to assist with IADLs and ADLs. Daily routines will need to be adapted and restructured. Things like household chores, shopping, preparing meals, providing transportation, how to help arrange doctor's appointments, how to help manage finances and legal affairs. Potentially at some point they may need assistance with how to help bathing, dressing, grooming, etc. Also, there may be increasing needs to help manage behavioral symptoms such as aggressive behavior, wandering, depressed mood, agitation, anxiety, even repetitive activity and nighttime disturbances. The coordination of care, like helping the person take medication, adhere to treatment recommendations, can be increasingly important for caregivers to help with during this time of moderate dementia. In regards to care planning, it's important to consider how supportive decision making can be very helpful for caregivers to understand during this time, in addition to providing anticipatory guidance for care needs, which may include learning about what respite services are available in the community, such as support groups and adult day service programs. There are also things like paid in-home services, nursing homes, assisted living facilities, or they could even hire others to provide care. So it is really important, in summary, for caregivers to understand all of their options for getting help, because it cannot and should not always be up to them to figure everything out in regards to helping the person with dementia. And they should know that there are other options if need be. Again, caregivers will continue to have increasing emotional support needs, and this may entail accepting the changes that are happening in their loved one, managing their own stress, and managing their own well-being. And here are a bit more details about that safety assessment that I told you I would give you more information on, that caregivers should really consider doing when someone is increasingly getting into those moderate dementia stages, or honestly, even ideally earlier, before you have those safety concerns. And I've provided a copy here of the first page of a 2-page handout from the Alzheimer's Association of a home safety checklist that anyone can print off and you can give to, caregivers or anyone for that matter, family or friends. That's really just helping to prevent dangerous situations from occurring in your home. And this is really, when you're doing a safety assessment, you're wanting just to consider, is there an immediate safety risk for the person with dementia to be alone? And also, how often are they needing supervision? Are there concerns about wandering or unwitnessed falls? And helping think through all of these questions can really help maximize safety, but also can help individuals stay independent for as long as possible by helping to minimize any risk of injury or harm, and help think through and recognize when someone really is no longer safe to be living independent any longer. So again, another way to think about caregiving needs, in this case, moderate dementia, is to frame the needs around the key resources available to the caregivers in the healthcare setting and in the community. So after a diagnosis, there's a period of really prioritizing the dementia, when you'll focus on the caregiver's capacity to support the person with dementia. And here, again, referrals to social workers and care managers continue to be very helpful, including now increasingly for things like advanced care planning. Pharmacists also may increasingly become part of the care team for medication assistance. And you'll also see increasingly that they'll have a need for home health coordination and other home health team members, including for things like respite, skilled nursing care, occupational therapy, physical therapy, etc. And there are a variety of community organizations that may be very helpful also during this time, including things like Area Agency on Aging for support with things like meals or transportation. Also, just don't forget extended family members, social networks, but also faith-based community organizations that may provide immense amount of support to caregivers. This is a time where caregivers may increasingly consider assisted living facilities and assisted living residencies. So this may be a time where it's very helpful to start thinking about providing that type of information to caregivers. And also, there are other types of care that are not assisted living facilities, but that also may provide some relief for caregivers, including adult day centers or PACE programs. PACE stands for Programs of All-Inclusive Care for the Elderly. And those are programs for individuals 55 years or older who help older adults live basically in the community for as long as possible. And PACE programs provide comprehensive care through these interdisciplinary teams of a variety of disciplines like a PCP and a nurse, PT, OT, dietitian, etc. Also, during the moderate dementia stage, there'll be increasing communication and behavioral challenges, which will obviously require increasing support and skill building by the caregiver. So in the healthcare setting, you could imagine that referral to behavioral health may be very helpful for the caregiver. And from a community organization perspective, there are a variety of different resources, both online and in person, that may be very helpful. And just want to make a particular shout out to one organization or resource called CareBlazers, which is an online resource. It's actually something that you can sign up for. It's a training for caregivers, also provides a training for professionals as well. But from a caregiver perspective, you sign up for it and it provides videos and weekly support groups that you can access online to help you basically increase your capacity for caregiving and really empower you as a caregiver with great online reviews for those that have taken the training. And obviously there are also other various online resources and dementia-specific caregiver support groups available. So during the late stages of dementia, the caregiver role really focuses more on preserving quality of life and dignity. And the information that a caregiver needs there may entail how to support the increasing care at home, and or may again start to focus more on how to move the individual to a long-term care facility, or at some point maybe even to hospice care. And continuing again to increase information on how to manage symptoms, including increasing physical symptoms and behavioral symptoms. And then for care planning, here you'll start to see increasing surrogate decision making kick in, and also anticipatory guidance for what's to come, and increasing emphasis on end-of-life planning conversations, which are just absolutely vital to start having here, but also earlier on in dementia caregiving. And I will address some of this in subsequent slides about caregiving well-being, but dementia caregivers have a unique and complicated grief that really ought to be addressed head on. They are at very high risk for isolation and loneliness and very high burden and stress. And so they continue to have the need for assistance with their stress management and assistance with addressing their personal, social, and well-being needs. So let's talk a little bit about caregiver well-being, and specifically as it applies to dementia caregiver well-being, because there are some really unique things to being a dementia caregiver that are worth pointing out and knowing. So dementia caregivers have a very high level of burden and stress, and 1 in 3 dementia caregivers report their health has worsened because of caregiving, and that's compared to 1 in 5 caregivers of older adults that don't have dementia. So you can see here that there's a disproportionate burden here on the health of dementia caregivers. Dementia caregivers also report significantly higher depression and anxiety than older adults that are not caregivers or caregivers to those who are not taking care of people with dementia. And the prevalence of dementia and anxiety in this group are staggeringly high. Prevalence of depression is 36%, with the prevalence of anxiety being 44%. We also see that caregivers themselves have a high rate of having a chronic health condition. So 58% themselves have a chronic health condition. So they have their own health needs to begin with, which is important to know. They also report having more financial difficulties as a result of caregiving. They have a greater decrease in their social networks from caregiving, and they report more loneliness. And if you can see in the figure here, the percentage of dementia caregivers who report high to very high stress due to caregiving, 59% report the emotional stress of caregiving to be very high, and 38% report a very high physical stress of caregiving. So the burden is just immense, and it does appear that there is a disproportionate burden on dementia caregivers compared to other type of caregiving. And I'll go over in a little bit why we think that might be, but one potential explanation here maybe because of the type of assistance that dementia caregivers are providing in regards to the physical assistance. So you can see the proportion of caregivers of people with Alzheimer's or other dementias versus caregivers of other older people who provide help with specific activities of daily living. So basically, in summary, this means do caregivers of older adults without dementia, are they providing assistance with ADLs to the same degree that dementia caregivers are? And you can see the purple versus light blue, absolutely not. Dementia caregivers are providing very extensive assistance to persons with dementia, dealing with incontinence, dealing with toileting, dealing with feeding, bathing and showering, getting dressed, getting in and out of beds and chairs, the activities that they're helping with. When you're talking about caregiving in severe dementia, these ADLs, this is very extensive work. Not only is it physically grueling, but it's very mentally demanding. And you can imagine if the person that you're helping is also virtually non-communicative and may also, on top of that, be your loved one that you are no longer able to have a conversation with. I mean, the mental toll that may have taken on you at that point. So you could start to see how this may all add up to just not be as equitable of an experience in regards to the burden of a caregiving experience when we see that there's this disproportionate impact on health. We also see that there is a unfortunately unique experience with grief in regards to dementia caregiving. So we know that it's common for caregivers to have feelings of loss and grief. But for dementia, we see that in comparison to other chronic diseases, the grief comes well before the actual death occurs. And this continues through the progressive disease course in response to the prolonged losses. So grief is this unique experience where we actually call it chronic grief. And you could imagine all of these different losses that a caregiver may be grieving in regards to their own personhood, the loss of the life that they anticipated for themselves and for the life of their loved one, the loss of the bond of their relationship, of just living life as planned before the diagnosis. So it's this chronic grief that again begins well before the actual death. Grief during bereavement is associated with increased risk for health impairments and mortality. And we see that 20% of bereaved dementia caregivers experience prolonged and exacerbated grief reactions. And we call this complicated grief. And this is associated with chronic health issues and even immune compromise for up to 3 years. So in summary, dementia caregivers not only experience chronic grief, but they also experience complicated grief that is associated with health issues and health complications. And so just to reiterate, bereaved dementia caregivers experience worse outcomes, and this can include depression, loneliness, stress, and guilt. And we think they may experience worse mental health outcomes due to a variety of really unfortunate circumstances that in some cases are kind of unique to being a dementia caregiver, and that includes the reduced ability to communicate in the final stages of illness, so in the final kind of severe dementia stages, an increased length of time in the caregiving role in dementia, a higher level of the perceived caregiver burden. Again, we refer back to that slide and thinking about how extensive of care they're providing being a dementia caregiver. The presence of significant and prolonged pre-death grief resulting from ongoing losses as dementia worsens. So again, we know that this is chronic and very complicated grief. The frequent need for LTAC placement, and so we actually know, evidence tells us that when dementia caregivers have a loved one that is placed in an LTAC, it's actually associated often with increased guilt in that circumstance and increased loneliness and stress. Instead of, you might wonder if they have some sort of sense of relief, but it actually usually worsens their mental health, and they often have experienced quite a bit of guilt, unfortunately. And then reduced likelihood to receive hospice services prior to death for persons with dementia. Which has actually been shown, as you can see at the bottom of the slide, to improve caregiver depression and anxiety. So there not only has been shown to be improved outcomes from quality of life from a person, individual standpoint receiving hospice services, but also from a caregiver standpoint. So you put all of these factors together and it really kind of creates a circumstance and situation that you could imagine where bereaved dementia caregivers are at a very, very high likelihood to experience poor mental health outcomes. And so then you're thinking, well, certainly we have a system set up where we're gonna reach out to them with open arms and be ready to support them. And unfortunately, support provided to bereaved caregivers is severely limited, and it's just a very lacking in our healthcare system and even in the community. And so this is really an area that just needs a whole heck of a lot of work. And so when we think about things that we know are helpful, that we know have evidence, as I already alluded to, we see that hospice enrollment for persons with dementia is associated with reduced post-death caregiver depression and anxiety. So we know that that can be helpful. So that is something that we can potentially kind of allude to with caregivers. Hospice for a variety of reasons, including this. We also know that support groups are helpful. And that's definitely something that we want to suggest from a more formal support standpoint, in addition to informal support, friends, family, spiritual communities. But this is just an area that really needs a whole lot more work for our caregivers. So speaking of what needing a whole lot more work for our caregivers, another area of evidence that actually does have a relatively robust literature base would be interventions for caregiver well-being and burden as a whole. So this is different and separate from just specifically focusing on bereaved caregivers, so post-death. This is kind of focused on interventions for caregivers at any point in time in the caregiving experience. What do we know about like how to help our caregivers in regards to positively impacting some aspect of their overall well-being, or kind of taking away some aspect of their burden? What interventions have been studied? What do we think can be helpful? And there is some literature in this area. I can tell you there's not one gold standard, not one thing that stands out and says, like this is the one intervention that we know that's the most helpful. But there's a variety of things that have been shown to be likely helpful, and these are all great to know about, to have in our back pocket, and to kind of, most importantly, to let caregivers be aware of, that they should know about, and to reach out for if they're ever interested in. And so kind of just going from the top, case management again. So this is definitely something, case or care management, that can be provided through a healthcare setting. Most primary care settings have access to a case manager or a care manager that can really do an assessment and provide information and referral to a variety of access to community organizations and community-based referrals. And so that is within itself actually an intervention for caregivers that has the potential to improve their well-being. So that's something to really take seriously in regards to, in the healthcare setting, getting caregivers connected to those social workers and care managers. Psychoeducational approaches just include providing information about the disease itself. So even just taking the time to say, here is, let's say we're talking about Alzheimer's disease, here is information about Alzheimer's disease, here are the resources on, here's how to access the Alzheimer's Association website, here are the different services the Alzheimer's website can provide you. That actually within itself is also an intervention, because you are providing information about the disease, and therefore you're lifting a burden for the caregiver to have to access that information themselves, and you're helping them figure out how to navigate a website, and helping them figure out, if you want to learn further information, here's how to go. So that does have, that is something to think about, of taking seriously, and why we've been talking about so seriously of how important it is to provide caregivers with information. Counseling, so that referral to behavioral health that we've talked about a few times, and in particular with this, the potential difficulty of the relationship that a person may have with their loved one, and how that's going to change over time, particularly as their loved one changes themselves. So one thing that counseling can do is aim to resolve pre-existing personal problems that may complicate the caregiving experience and reduce conflicts between the caregiver and the care recipient, and or just to improve family functioning. There are also many, many other potential aims of counseling, but that is one. Psychotherapeutic approaches, and so this is where, CBT really comes into play. So establishment of a therapeutic relationship between a caregiver and a professional therapist. For example, CBT that might focus on identifying and modifying beliefs related to emotional distress, developing new behaviors to deal with caregiving demands, and fostering activities that can promote caregiver well-being. So again, this is also a referral to behavioral health as well. Respite that we've talked about multiple times, also a caregiver intervention that can improve well-being, and this is just providing planned temporary relief for the caregiver through the provision of substitute care. So those adult day services that we've reviewed that the caregiver may want to, should have information about and may want to consider at some point. In-home or institutional respite care. And so again, an intervention that, something that we're going to have in our back pocket that we'll be talking to caregivers about, but is actually within itself an intervention. Support groups, so these are less structured technically than the psychoeducational or psychotherapeutic interventions, but it provides caregivers the opportunity to share personal feelings and concerns. And I really can't stress enough that I think support groups are really helpful, or really important, I should say, for caregivers to look into, because I do think that talking to someone that is going through what they are going through can be very helpful. Having said that, the early disease support groups that the Alzheimer's Association offers, I think are immensely important to know about, because I have heard anecdotally that caregivers that, attend support groups or read online in support groups for later stage, when they are in the early stage, I think that can be, very frightening and very overwhelming when you are just getting involved in caregiving in the early stage. And so I do think kind of specifically modifying your experience or tailoring your experience to where you are in the caregiving, journey can be potentially very important. And then obviously there are multi-component interventions that combine multiple forms of these interventions, education, support, and respite, into a single long-term service. And these interventions you would potentially access at in your healthcare setting if you were in a particular institution that provided a specific type of intervention. But all of the other interventions we've really discussed already today as different types of support that we would be wanting to talk about with the caregiver. And these are, caregiver needs that we would be wanting to address with any sort of caregiver that we're interacting with. Okay, wrapping up here, the big takeaway that I want everyone to really walk away with is we need to be better at identifying our caregivers. I put care partners here, but our caregivers, and supporting them. And I think that they are just kind of seen as like the other person in the clinic room that, listens to when we're collecting a history and chimes in every once in a while. Or maybe they're the historian as the dementia progresses on and they get into more moderate and severe dementia. But they themselves are, someone who needs their own care and their own support. They, in some ways, are, their own patient. And but even if they are not your patient, or even if you're interacting with them in a non-clinical care setting, I just think that it is of utmost importance that caregivers are identified and supported and given, the resources that they need, because with the rise of the aging population and with the rise of Alzheimer's disease, oh my goodness, are unpaid caregivers the ones holding our world up? And I'm not saying that's the way it should be. In fact, it definitely shouldn't. All of these unpaid caregivers should be paid appropriately. And that is the talk for a different day. But in the meantime, recognizing what I have the power to do myself is, as a family medicine physician, is to, give these caregivers the respect and recognition and support that they deserve. And so, first is recognizing that there's a high prevalence of chronic disease and mental health needs in this population, even at baseline. Also recognizing that dementia caregiving has disproportionately negative health impacts and high caregiving demands compared to caregiving older adults without dementia. So this type of caregiving seems to be very demanding, very burdensome, and really negatively impacts those who undertake this type of caregiving. And when you are a caregiver for dementia, you need information, you need assistance with care planning, you need referrals. And knowing what all of those different interventions were that we just discussed, kind of the psychoeducation, the psychotherapy, the case management, etc., can be very helpful. And again, understanding the disproportionate negative health impacts really can arm us in our own way to be better prepared to say, when we interact with caregivers, we should really consider assessing them for depression, for anxiety, for loneliness, for stress, and for other measures of well-being, because we know now really we better understand what they're going through. And in addition to providing them with the support and resources that they need, we should also assess them for their well-being so that we can better understand other aspects of their mental health to see if we need to be, for example, treating them for depression and anxiety, or treating their loneliness, or if there are other ways that we could be helping them. We should consider interventions for reducing caregiver burden and stress, including referrals to behavioral health, support groups, and respite. And finally, I do think it's very notable that hospice has been shown to decrease post-death bereavement for dementia caregivers. So I really feel like, it's for the fact that hospice is underutilized in this population specifically, and specifically that hospice has been shown to be particularly helpful for the bereavement for these caregivers. I think that is a takeaway that we should all kind of really think about. Okay, I'm just going to end by re-highlighting some of the resources that we went over today. So all of the resources mentioned on this slide I've already reviewed, including the Alzheimer's Association helpline, early stage support groups from the Alzheimer's Association. We talked about care planning resources and emotional support resources, including the CareBlazers site, which I would encourage everyone to go to if you haven't already. And then I'll also just make note at the bottom that there are a few other resources that, including the VA caregiver program, which is a really great resource. And we talked about the PACE program as well. And then moving on to the last slide, there are a couple of other final resources that I will share with you. Okay, so talk about dementia. I actually, can't remember if I said that, if I talked about it last week, but I think I may have. It is from the Colorado Department of Public Health, from their Alzheimer's disease and related dementias webpage, and they have information specifically for caregivers as well. The Best Programs for Caregiving is a free national repository of evidence-based resources for care partners, and there's a page for care partners to find resources and one for professionals to identify resources for care partners. And you can even narrow down by location, which will provide a list of local or virtual available resources. That's really cool. The Family Caregiving Alliance, you can find information, support, and resources for care partners on that website. Mile High United Way, or 211, is that growing centralized repository that you probably heard of, and they do have ADRD resources, services, and supports on there, as well as other social services that people can access when they when they need them. And then the Colorado Respite Coalition is also, it's listed in the Mile High United Way 211 repository, and you can find respite care and related resources there. And the Dementia Caregiver Roadmap is from Dell Medical School, and it's available for health systems that are interested in implementing support for care partners. So these are just a few of many, many resources, but some that are kind of popular amongst us locally, and you know, in thinking about caregiving resources that I would definitely wanted to share, in addition to the ones on the resources on the other sites, or I'm sorry, on the other pages. Well, thank you so much for bearing with me all the way through, and this concludes my presentation, and I will just jump to the last slide. All right, here's my email. If you have any questions, please feel free to reach out. And thanks again for bearing with me 2 weeks in a row. And I look forward to discussing the case with you all once again. Talk soon.